All right. Thank you so much for joining us tonight at Hive. We are so excited to welcome Taylor Hanton. She is a neonatal nurse practitioner for Intermountain Hospital and Intermountain Health Care, and she has been working in this field for nearly 20 years. And we are really excited to have her talking about what to expect when baby arrives in the hospital. And we are just so thrilled to have you with us. If there are any questions, feel free to put them in the chat, and we look forward to learning some more about what to expect when baby arrives. So Taylor, we'll send it off to you.
Hey, I'm just going to share my screen. Just give me 1 second. Okay, so yes, I'm a neonatal nurse practitioner. I'll just tell you a little bit about me, just so you have an idea of who's talking with you. I work for Intermountain, but I cover a lot of the Intermountain hospitals. A neonatal nurse practitioner generally works in the Newborn ICU. So I work at Primary Children's Hospital, Intermountain Medical Center, LDS Hospital, Altaview Hospital, and Heber Valley Hospital, as well as Park City. So I get to take care of a lot of the babies in our state. So I wanted to give you more of the experience of what this is like for your baby and what we learn from your prenatal visits about your baby. I know becoming a new mom is very exciting and your own body goes through lots of changes, but there's a lot that goes on in your prenatal visits and during your labor and delivery process that tell us a lot about how your baby's doing and what we can anticipate for your baby's care. So that's kind of what I want to focus on. I live in the Park City community, and so by default, I'm your friend, and I want you to reach out to me. I provided my email on this slide. So if there's anything I cover that you have questions on, concerns, just want to know something more about, feel free to email me. Be happy to talk to you and answer any questions individually if it's something that you didn't feel comfortable sharing during the presentation. So the objectives for today, I want to discuss the different levels of hospitals and what that means for the delivery of your baby. So we'll talk about well baby nurseries versus the newborn ICU. We'll talk about the importance of prenatal care from your baby's perspective. So what we learned about your baby's growth and glucose and group B strep screens. And then we'll talk a little bit about newborn care. So state metabolic screens, critical congenital heart disease, and the medications that are standardly given to your baby at birth. Feel free to ask questions during the presentation. I'm used to interruptions, so ask away. So first, where should I deliver? What's the difference between the different Intermountain hospitals for your baby? So the care delivery models that are offered are generally a community-based service, which is a well baby nursery, and specialty-based services, which has the newborn ICU. So the smaller based community-based hospitals, they generally have telehealth. If you didn't know what telehealth is, it's a virtual computer system that connects our smaller hospitals to a newborn ICU. So for example, at Park City and Heber, every delivery room is connected with a telehealth monitor that if we call into it, a neonatologist from Intermountain Medical Center or Utah Valley will appear on the screen and we can directly communicate and they can see exactly what's going on with your baby at Park City or the smaller hospitals, even LDS, Heber as well. The community-based hospitals have specialty clinics, they have inpatient pharmacy and primary care clinics versus the bigger hospitals like IMC, LDS is kind of in between, Utah Valley. They're inpatient rehabs, they're skilled nursing facilities, they have outpatient rehabs, and this is more specialty-based care, and this is where the newborn ICUs are located. So what's the difference between a well baby nursery and a NICU? Well, well baby nurseries in our area are Park City and Heber Valley. So we have what we call LDRP rooms. So that means that you labor, deliver, recover, and it's a postpartum room. So you're in the same room when you're admitted throughout your delivery. If you have a C-section, you will be admitted to one room and then do your recovery in a separate room. But if you're having a regular vaginal delivery, you're in the same room the entire time. We have what we call couplet care. So couplet care means that the nurse who labors you is there at your delivery and then becomes the same nurse that takes care of you and your baby. So the couplet is mom and baby. And then we have what we call a well baby nursery, but generally speaking, when you're at a smaller hospital, community-based hospital, there's a nursery available if your baby were to need more specialty procedures, but in general, the babies are located with their moms. We try to keep mom and baby together as much as possible. So what's the difference with the hospitals that have an ICU? So those hospitals generally have a labor and delivery unit, a well baby or postpartum care unit, and a newborn ICU. So for example, at LDS, Utah Valley, Intermountain Medical Center, and even the University of Utah, you labor and deliver in one area. Your baby can go to the well baby nursery or can be stay with you in your room. And then there's the newborn ICU that's separate. So there's 3 separate areas that function pretty independently. When you're at a smaller hospital, that whole process is contained in one unit. So for example, when I'm working at Park City, I am very well in touch with the OB delivering the mom, the OB nurse, and then she becomes the baby's nurse. And so it's a much smaller care team. And so we're a lot more involved with what's going on with the baby because we're one unit versus separate units in the bigger hospitals. So LDS, we generally do babies that are 32 weeks gestation and above. An Intermountain Medical Center, Utah Valley, University of Utah, they do all gestation babies. So those are your micro preemies. So LDS, you can kind of view it as an intermediate between like a community hospital like Park City or Heber. We deliver down to 35 weeks. And then LDS is down to 32 weeks. And then Intermountain Medical Center is basically all babies. And then as I previously mentioned, the L&D, postpartum and nursery are all totally separate departments. So you have a different care team when you're in L&D, then you have a different nursery when you go to postpartum, and then there's a different nursery nurse for your baby if your baby were to go into the nursery. So what's primary children's then?
Taylor,
yes.
quick question for you. What if you are in a smaller facility such as Park City or Heber that does not have a NICU and your baby needs the NICU, what are the processes and steps that are taken, in general? I know there's outlying scenarios and emergencies, but what would your care team do beyond the telehealth if that wasn't enough?
So all Intermountain hospitals are able to stabilize any critically ill infant. So the luxury of being at Park City Hospital is that you are on an expressway corridor. So we've had babies, parent moms, I should say, pregnant moms that are driving through, see the hospital sign, they are in labor, they're bleeding, there's something going on, they come into our hospital, and they may be 28 weeks gestation. We know how to deliver and stabilize that baby until life flight can come and transport that baby. So we have the resources and the knowledge and the skill to stabilize any newborn until life flight can arrive. So once we have the baby that's born, we kind of do our evaluation. If it's less than 35 weeks, there's no question, we'll just arrange transport. And if we can get life flight there prior to delivery, even better, then they're there at the delivery and they transport the baby out. If we can transport mom, if it's a baby that we know is going to be needed to be transported out, so say a 30-week baby, we will try to transport mom while she's still pregnant, so she's in the same hospital as her baby. But sometimes you can't, because you can't risk the delivery of the baby during transportation. So if it comes to that point, then we will deliver the baby, we'll call it our specialty team services, and we'll stabilize, and then we can use telehealth to help guide care if needed. But that's kind of the benefit of me being at Park City, is that I work in these higher acuity facilities, and so I'm very comfortable taking care of babies that our hospital might not normally see.
Awesome. Thank you. Yeah.
And we'll talk a little bit about that too, about what this means when you're pregnant and kind of making that decision that's right for you and your family. So primary children's, a lot of people think, well, well, I'd rather just have my baby at primaries because I don't want my baby to be transported. Well, there's no labor and delivery unit at Primary Children's. It's a children's hospital. So where are the babies there? Well, we have a newborn ICU at primaries. We have a cardiac ICU for newborn babies. And we also have an infant unit. So our babies can be spread out between those 3 units. Generally speaking, if your baby is born and is not gone home, it'll generally go to the newborn ICU. Sometimes we'll do admits from home if it's like a bilirubin issue. If it's a term baby that has cardiac disease, that baby will sometimes go to the cardiac ICU directly. If it's a preterm baby with cardiac disease, that baby will generally go to the newborn ICU. So there's a lot that goes into what's going on with the baby, how old the baby is, what the baby has been exposed to what unit we put that baby in at Primary Children's. Primaries is also a transfer facility. So we accept patients from Utah, Idaho, Nevada, Montana, Colorado. So our bed space there is very limited and precious. Because we have to be able to accept high acuity newborns that need heart-lung bypass into our hospital at any time. So Primary Children's is a great resource. They have lots of specialties for genetics, cardiac, cardiology, etc. So we have to save those spaces for those babies that need those additional services. And since we cover not just the state of Utah or even the Salt Lake area, but multiple states, we try to determine where the best place to care for your baby is. So whether that's primaries, IMC, LDS, all of that goes into the decision of if your baby needs to be transported, what's the best place to continue care for your baby. Okay, so where should I deliver? Wow, this is a lot of information. It's very confusing and it's very scary. So how do I know where I should have my baby? The biggest thing is your health. So this is it's a collaborative decision. You talk to your OB, your midwife, how is your health? And you kind of make that decision together. You talk about what your concerns are, and you look at your health. If you are a mom that has a high risk pregnancy, we generally won't deliver you at a community-based hospital because we want to be prepared that if your baby or you need any additional resources, that we already know about ahead of time, we want you to deliver safely in the facility that is best for you and your baby. So this is a collaborative decision. It's something that you should be informed about. Prenatal care, we have something called maternal fetal medicine. So sometimes you might hear it referred to as MFM. And this is a service. So if you're being cared for at Park City or a smaller community-based hospital, and there's any concerns that your OB or midwife have about your pregnancy or what they're seeing on ultrasound, they can consult this higher specialized area and they can talk with them. And they could also help decide where the best place for you to deliver your baby, not just for your own care, but for your baby's care too. Your fetal ultrasounds will tell us a lot of information about how your baby is growing, how structurally your baby looks, and then also your GBS screen, which we're going to talk a little bit more about. So prenatal care. So this is our first time that we get to learn stuff about your baby. So I know as a new mom, you are excited you're pregnant and you're wanting to see how your body's going to change and what this means for you. But this is also the very first time that we get to learn about what's going on with your baby and how your baby's growing. So basic prenatal care, we learn about the growth of your baby. We learn about the function of your placenta. If your placenta isn't working very well, sometimes your babies can be small. So we'll talk a lot about, and you may or may not hear during your prenatal visits about your fetus and the size of your fetus. And so we often talk about AGA, SGA, or LGA. And what that means is appropriate size for gestational age. So AGA is just a normal size baby for how old the baby is. So if you're a 40-week baby, your baby is the size it should be. SGA means small for gestational age. So say your baby is term, say 38 weeks, but your baby is the size of 36-week gestation baby. So that's small for gestational age. And then LGA is, as it says, the baby is large for gestational age. So maybe your baby is 37 weeks, but she's really the size of a 40-week baby. So that tells us a lot about what we can anticipate, not only the delivery of your baby, but what things that we need to be anticipating when your baby is born. So the fetal ultrasound, tells us a lot about anatomy. But just to give you an idea, and we'll talk about this a little bit later, that fetal ultrasounds, they're great and they can tell us a lot of information, but this is where maternal obesity can be troublesome because you're going through a lot of those layers to see the anatomy of the baby. So if there is a large adipose layer, it's very difficult to not only find the structures, but to see them accurately enough to discuss what their structure and anatomy is. And just to give you an idea, a baby's heart is the size of its fist. So when you're talking about even a term baby, the baby's fist is the size of its heart. So if you're looking at a 20-week gestation baby and looking at the heart to determine what the heart status is, you can see that that can be very difficult. If you add obesity on top of that, you add the skill of the sonographer, you add the position of the baby, how the baby is in utero at that time of the ultrasound. There's a lot of things that can complicate actually looking at that picture. So fetal ultrasound is very helpful, but it's not foolproof. And then we can also learn about your baby's fetal position. So we want the baby's head down, right? So if the baby's breech, that can mean that we might have to go to a C-section, or we might have to try to do an aversion and try to rotate that baby around. So prenatal care is very important just for the basics of the baby. But then we also have some labs that are done. So the glucose screen. So the reason that glucose screen is done when you're pregnant is to look for gestational diabetes. Gestational diabetes is diabetes that is diagnosed for the first time during pregnancy. Why some women get it and some don't is pretty unclear, but it's probably related to the hormonal changes during pregnancy and how glucose is processed. So glucose levels can return to normal after pregnancy. So just because you have gestational diabetes doesn't necessarily mean you're going to be diabetic. However, you do have a higher risk of developing type 2 diabetes later in life, or even after delivery. So this can be managed with diet and exercise, and there's also some medications that can be prescribed during your pregnancy to help control the diabetes, your glucose levels. And these moms also have a higher risk of hypertension and preeclampsia. Sorry about that. So what does that mean for your baby? Well, your babies generally tend to be bigger because there's more glucose available, there's more insulin, and more insulin causes your body to take up more of the glucose. So these babies grow really well. So they tend to be larger. So large babies, you have a higher risk for preterm birth. You have a higher risk for birth injuries during the vaginal delivery because the babies are so large. Sometimes they're difficult to move through the birth canal and come out. So then you have a higher risk for C-sections. The babies also have a higher risk of having low glucose. This is often referred to as hypoglycemia. You hear that term a lot. If your baby is born and you have gestational diabetes, and there's actually a hypoglycemia protocol that if your baby falls into certain categories or risk factors, that we automatically start screening your baby for low glucose, because the glucose is what feeds your brain and your heart and your organs. And you want to make sure you have a normal glucose level. So these babies are at high risk to have a low glucose. So that means that we want to get food into your baby. That means that we might have to supplement your breast milk with pasteurized human milk or formula, whatever preference you have, to keep the food supply, the glucose supply up. Sometimes if we can't keep that up with enough food, then sometimes we might have to put an IV in your baby and give your baby glucose through an IV. These babies also can sometimes have at a higher risk for having respiratory distress. And they're also at higher risk for developing obesity and type 2 diabetes themselves later in life. So this is something that you want to take seriously and try to do the best you can with managing gestational diabetes if you have it. The other thing I want to talk about that we have part of our prenatal care is the group B, they call the GBS screen. So group B streptococcus, or group B strep, as it's commonly referred to, is a common bacteria that lives in the vagina and rectum. It's different than the group B strep that causes strep throat because it lives in a different area in the body. The unborn baby can be exposed and infected once the mom's water breaks. So once you have that amniotic sac that surrounds the baby and protects the baby, once your water breaks, and if you have GBS, if you have group B strep, then that is now allowing the broken water allows the bacteria to try to migrate up into the area where the baby is. This can cause lung infections or pneumonia, blood infections, and even meningitis. So meningitis, if you remember, is an infection in the cerebral spinal fluid that surrounds your spinal cord and your brain. So it can be pretty serious for babies. So part one of the GBS screen, there's actually I like to think of them as two parts of why we do it and why it's important. One is that it's a national standard to screen all pregnant moms. And this is because 1 in 5 pregnant women carry GBS but have no symptoms. This isn't, GBS isn't something that causes illness. So you're either GBS, you either have group B strep in your vaginal rectal area or you don't. It doesn't mean anything. It's not sexually transmitted. It's just something that you normally carry or you don't. You can test positive one pregnancy and negative in another pregnancy. It's a quick swab. They do it about 36 weeks gestation. It takes about 1 to 2 days to get the results back. And it doesn't really mean anything other than how we treat your baby once your baby's born. So sometimes we can do this test a little bit earlier if it looks like you're going to have a preterm baby, because it tells us how to best manage your baby. That sometimes we'll do this GBS screen on moms a little bit earlier if it looks like they're going to go into preterm labor. So the other reason it's important to know about group B strep status in moms is that it's the most common cause of newborn infections. And based on the Utah Department of Health, the incidence of GBS infection is higher in Utah compared to the national average. So it's 0.4 cases versus 0.22 cases per 1,000 live births. So this is something in particular that our state really takes serious and, try to follow up and monitor these babies. The symptoms can be mild in the newborn, but if it's left untreated, it can cause death. So screening all pregnant moms for GBS, as well as treating those who are positive, has significantly reduced newborn infections. That's the good news. We can do something about this. So what do we do? Okay, so you test positive. Okay, so what's that mean? So to minimize the risk of passing GBS onto your unborn baby, you will probably receive IV antibiotics during labor. Sometimes extra monitoring and treatment, and we'll talk about that in a second, may be indicated for your baby if the antibiotics are administered close to the time of delivery. So we like to have at least 4 hours prior to delivery of the baby after the administration of the antibiotics. So for some reason, your labor goes really quick and your baby delivers after 2 hours, we may do some additional monitoring for your baby just because the antibiotics didn't have enough time to be effective. If your water hasn't broke and labor hasn't begun and you're having a C-section, you may not receive these antibiotics because the risk of your baby being exposed to this bacteria is pretty low. So what does it mean for my baby? So if we know a mom is GBS positive, and we will know first if mom has received antibiotics prior to delivery or not. And then we will monitor your baby a little more for signs of GBS infections. So we do more frequent vital signs. So we watch your baby's heart rate, how fast your baby is breathing, the oxygen saturation in your baby's blood, and your baby's temperature. We may also do some screening labs or blood cultures to further assess whether your baby has an infection, and your baby may need antibiotics. So there's other indications for extra monitoring in GBS babies or GBS positive moms. It's if moms have tested positive in previous pregnancies for GBS, if they had previously had a baby that had GBS infection after birth, if mom has had a urinary tract infection during pregnancy that was caused by GBS, if the baby is preterm and they haven't yet been screened, so we don't know what the GBS status is. And if the labor is preterm and the GBS status is unknown, and there's risk factors that develop during labor, such as maternal fever, or the membranes have been ruptured for greater than 18 hours, those are all these things can require extra monitoring for your baby, just because they're at a higher risk of having GBS sepsis or infection. So what do these babies look like if they do have an infection? Well, they can have an oxygen requirement. They can have an increased work of breathing, whether that's breathing fast or retractions, which means that you see little areas pulling as the baby is trying to breathe, as they're trying to pull in oxygen. And there can be grunting. Grunting is sometimes tricky because it sounds like a newborn newborn noise. It's just like a little and it's the baby's way of trying to expand their lungs to get more oxygen in. The vital signs can be abnormal, so not just a high temperature, but a low temperature is very concerning in a baby. They can have fatigue, disinterest in oral feeding, and decreased urine output. And if your baby is sick enough, based on the clinical exam and the lab work, we can most often continue care in a community hospital or our well baby nursery, so we can give IV antibiotics and continue to monitor. But if your baby is really looking sick, this is something that we may need to transfer your baby for. So that's why it's so important. The more we can know about your baby prior to delivery, and if you're you've had prenatal care, we know what your GBS status is, and we treat moms appropriately, the more we know about your baby and the more we're able to identify and treat the baby appropriately. So our overall goal is to treat babies who are at higher risk of being infected with GBS bacteria while limiting the exposure of all babies to antibiotics. We don't want to give antibiotics to babies if they don't need them. So in order to do this safely, we need to know mom's GBS status prior to delivery and treat her accordingly. And we also need to monitor those babies closely during the newborn period to determine if further treatment is indicated. So newborn care, we'll talk about mandatory state screens and some newborn medications. So mandatory state screens, there's two screens that are mandatory in the state of Utah. One is the newborn metabolic screen, and the other is a critical congenital heart disease screen. These two screens are in place to help detect specific disorders and to identify them early, and so we can treat them effectively. So the Utah Newborn Metabolic Screen checks for over 40 disorders. So this is kind of state dependent. States determine what disorders they want to screen for. Utah is one of the better states, meaning that we screen for more disorders compared to other states, but it really is state dependent. So our state metabolic screen looks for hormone abnormalities such as hypothyroidism, adrenal gland, inborn errors of metabolism, for example, like PKU, immunodeficiency disorders, red blood cell abnormalities, and cystic fibrosis. There's two checks. The first one is a blood draw. They just poke the heel and they just put little spots of blood on a special card. This is done 24 to 48 hours after birth and before hospital discharge. So the reason we wait 24 to 48 hours is because we want the baby to be able to start metabolizing breast milk or formula. Because if you have an inborn error of metabolism, you need to have some food so we can detect if there is a problem with digesting that food. So generally after 24 hours, but it'll be done before your baby's discharged from the hospital. Usually at this time, they'll also do a routine bilirubin check. And bilirubin is to look for jaundice, which makes the baby sometimes yellow, and is just a normal physiologic process in all newborns. But it can cause long-term problems if it's not treated and identified. So we generally do the newborn screen and the bilirubin at the same time. And then we have the results and we can determine if your baby needs phototherapy for the bilirubin or if we need to do rechecks for that. The second newborn screen is done after the baby's discharged. If you're in a small community hospital, sometimes our babies, they're in the newborn ICU, they're still in the hospital when they have their second one done. But this is generally done between 7 to 16 days after birth. And so if you're discharged from a well baby nursery, or even the NICU for that matter, prior to the 7 days, Your paperwork for the newborn screen will be given to the parents to take to the pediatrician's office, because that's where the second screen will be done. And it's a pretty big deal. Like if the screening cards, because they have special properties to the card to diagnose these disorders, they're very expensive cards. So it's really important to kind of keep track of where those cards are. So you'll probably have some very strict instructions on, this is your newborn screen card. Make sure you give this to your pediatrician after discharge. And that's why. Your baby's linked to a certain number, and each of those cards have the same number on them. So if it's missed, it becomes a little bit of a headache of figuring out where the screening is, did it get mixed up, or what happened to the cards. So kind of a big deal for the state. So the other screen that is mandated by the state is called the Critical Congenital Heart Disease Screen, or CCHD screen. So heart disease at birth, so critical congenital heart disease is heart disease at birth that requires surgery or a catheter-based intervention within the first year of life. These diseases affect blood flow into, through, and out of the heart, which affects the oxygenation of the blood. They can be difficult to diagnose, even with fetal ultrasound, as we previously mentioned. Fetal ultrasound has some limitations. And so it can be difficult to diagnose because often babies with critical congenital heart disease often do not exhibit signs of distress in the first few hours to days of life. So critical congenital heart disease, remembering those that require surgery or intervention within the first year of life, represents about 25% of all congenital heart disease. So congenital heart disease just means heart disease that a baby is born with. And that incidence is like 1 in 100 live births per our CDC. So 25% of those cases have the critical congenital heart disease that require additional treatment. And it's basically around 12 different conditions that fall into this critical congenital heart disease category. The CCHD screen can potentially identify 7 of the 12. So this screening is now standard of care across the entire US. So in addition to physical examination, pulse oximetry is a simple, non-invasive, so it means it doesn't, you don't have to break the skin or go into the body to do it, approach to help identify newborns with CCHD. Prior to this implementing this screening, 22 to 43% of newborns with CCHD were diagnosed 3 days after discharge. So these babies had a major congenital heart lesion, and they weren't even picked up until 3 days after discharge. This is due to the normal anatomical and physiological changes in the heart that occur after birth. So there's some vessels in the heart that are open when the baby is in utero. And once the baby's born, it takes some time for those vessels to close. So as those vessels are continuing to close, it can appear that the baby is healthy, but until they're completely closed, you don't know the baby has heart disease. And this anatomical closure can happen up to 2 weeks of life. So that's the importance of not only delivering your baby in a hospital and having close care when your baby's born, but also the importance of follow-up care with a newborn provider. So with the screen, so what if my baby fails? What's that mean? So we allow up to 3 attempts before a CCHD screen is considered a fail. They basically just put a little sticky monitor on your baby's right hand and on another extremity, and they compare the oxygenation values. So sometimes movement, the light, if your baby's upset and crying can affect the test. So we allow for a couple attempts before they consider a true fail. And then all that means is that we're going to do a little bit more investigation on why your baby failed. It does not necessarily mean that your baby has heart disease. So we'll do an echocardiogram on your baby, and this can be done in community hospitals as well. And the echocardiogram just is basically the same type of ultrasound that they do on you when your baby's in utero. It's just a little wand. They kind of put some gel on your baby's chest, and they just allow, the little wand has a camera, and it allows visualization of your baby's heart structure and function. So we can rule out a lot of those major scary congenital heart diseases with the echocardiogram. We'll also look for other reasons why your baby might have a low oxygen level. So to pass the screen, you have to have a greater than a 92%. oxygen saturation. So if you don't in one of your two extremities, we will look for reasons on why your baby has a low oxygen. And there's other things that can cause a low oxygen. Infection can be it. So we'll screen your baby for infection. We might do a chest x-ray. We're going to look for other reasons that your baby could have a low oxygen. And there's also false positives. So sometimes a baby fails. We do the echocardiogram. It looks perfect. We do some screening labs looking for infections. They're perfect. And your baby, will figure out why your baby requires oxygen. And sometimes your baby may go home on oxygen, but we need to rule out the scary stuff to make sure it's safe for your baby to go home. So what if my baby passes? Does that mean like, oh, my baby doesn't have heart disease? That's the tricky part. So as I previously mentioned, some of those vessels take up to 2 weeks to close. So sometimes they're open enough that the baby looks well and is not having any symptoms, but until that vessel completely closes, you may not see anything. So again, why it's important to keep your follow-up pediatrician visits, because they will assess and look for any indications that your baby may have heart disease. And there's also false negatives, because remember, the screening only detects 7 of the 12. So this is very early on in your baby's life. And it can take some time for some of these things to change to actually identify a disease process. So overall, through early identification, neonatal screening, both the metabolic screen and the CCHD screen, provide an opportunity for treatment that can lead to significant reductions in morbidity and mortality. So basically, the earlier we can identify something, the outcomes are better for your baby. And that's the importance of doing these screenings. So we'll talk a little bit about standard newborn medications. We'll talk about
Quick question for you, Taylor.
Yeah.
All of those screenings and potential problems with your new baby sound a little overwhelming as you're coming into being a parent for the first time. Do you have any like percentages or chances of that are kind of typical for either moms in Utah or maybe just kind of standard in the US that, they do these tests, but what to expect?
So the CDC, based on the statistics from the CDC, about 1 in 100 live births, babies will have some form of congenital heart disease. And then 25% of that number are the critical congenital heart disease. So is it something that we see often? We see it enough. I know this screen, I wish I remembered what year we started it in, but it was, since I've been a nurse practitioner, I want to say the last maybe 10 years we started this, maybe 20. Gosh, I can't remember. I don't want to misquote it. But it's something that we've relatively recently instituted as a state screen. And I know that we've detected kids that would have otherwise gone home that we were identified that had critical congenital heart disease that were able to get identified and treated. Sometimes or before we started doing this screening, the babies would go home and they might not have any symptoms until, a week of life, and they might have trouble breathing, or they'll take them to the ER and they'll say, oh, they have a low oxygen, and they might look, was the baby sick? Does the baby have a cold? Or is it heart disease? So the more, since we've instituted this screen, it's kind of helped us narrow in on what could potentially be causing the low oxygen saturation. And that's the important part that I really want new families to know, is that just because you pass doesn't mean you're out of the woods. There's still the importance of neonatal follow-up and taking your babies to the doctor's appointment. Sometimes people think, okay, I'm going to deliver in a hospital, the baby's fine. People have been doing this for hundreds of years. I don't need to keep all these appointments. They're just trying to make money or whatever it is that people don't want to continue with follow-up care. But there really is real reasons that you need to take your baby for follow-up. And unfortunately, if you don't, and your baby has one of these heart lesions, it can result in death. It's not something to take lightly. It doesn't happen very often, but how do you determine that you're not the one that's at risk? And looking at fetal ultrasound, I think that's sometimes a false reassurance. You're like, oh, my 20-week ultrasound was normal. I've been healthy. I had a good pregnancy. My baby passed the CCHD screen. Like, I feel pretty good. Don't want to instill fear, but just the importance of follow-up and just being educated on what that actually means and what follow-up is needed.
Oh.
And are there modifiable risk factors for these conditions, or is it mostly genetics from what we know at this point?
Genetics, there's some interesting things, like if mom had a critical congenital heart disease herself, the chances of her baby having a lesion is higher. Gestational diabetes or diabetes in general can increase the risk of having heart disease, again, because fetus being exposed to high levels of glucose causes a lot of heart growth and can affect the structural changes. And then genetics. Yeah, there's a lot that goes into it. Unfortunately, everybody's at risk, I guess.
Yeah.
There's people that are at higher risk, but really there's nothing that differentiates, anyone from not having this condition.
Thank you.
Yeah. Okay, so newborn medications, we'll talk about erythromycin ointment, vitamin K, and hepatitis B vaccine. Okay, so erythromycin ointment is administered within the first 3 hours of birth and is to treat ophthalmia neonatorum. This is an eye disease that's transmitted to the newborn exposed to maternal chlamydia or gonorrhea during birth. It can cause corneal scarring, ocular perforation, and blindness within the first 24 hours of birth. And this is a prophylactic treatment. So meaning you give it not because you think the baby has been exposed to it, but just in case the baby's been exposed to it. Giving this eye ointment can prevent this blindness. So this is one newborn medication that like a mom may be like, I never had chlamydia, I never had gonorrhea, like I don't want this given. Okay, that's great. I didn't think I had those things either, and I didn't, but to give a little eye ointment to a baby to prevent blindness is the risk to benefit. I recommend it. CDC recommends it. The AAP recommends it. It's just the eye ointment that goes into the eye. So if there's any chance that you may have been exposed, it's just best practice, standard of care for the baby to get it. But
And
this
it's one time of administration, right? It's not repeated.
Yeah, yep. Nope. It's just, it looks like Vaseline. It just basically goes on the, it's just like a ribbon of ointment. It looks like bacitracin really, just on the baby's eyes. And that's enough to, if your baby was ever exposed, to prevent these things from happening. So just a safety factor. This is one that some parents will say, well, we don't want it given, but that's fine. Just be educated about why you're not giving and what risk that you could potentially be taking for your baby. Another one is vitamin K. So babies are born with a deficiency in vitamin K. So very little vitamin K actually passes through the placenta for mom. And the bacteria that produces vitamin K are not yet present in the newborn's intestines. So by default, babies are born with a deficiency in vitamin K. So there is a condition called vitamin K deficiency bleeding. This is uncontrollable bleeding that can happen inside or outside of the body due to the babies not having enough vitamin K in their body to form a clot. So commonly babies with vitamin K deficiency bleeding will bleed in the intestines or in the brain, which can cause brain injury or even death. Babies are at risk to have this vitamin K deficiency until 6 months of age, until they start eating regular foods and have enough vitamin K stores. So breast milk also contains very low amounts of vitamin K. So if you're exclusively breastfeeding your baby will generally be on a multivitamin for this purpose to provide extra iron and vitamin K. So vitamin K, the standard of care is to give a one-time IM injection. So it's just a shot that goes into your baby's thigh within 3 hours of birth to treat vitamin K deficiency bleeding. There is an oral option. It's less effective because since it's oral, there's sporadic absorption from the GI tract or gastrointestinal tract. It's not recommended. If you do choose the oral option, it's given weekly until the baby is 3 months of age. It's compounded. So it means it's made in a pharmacy. So insurance generally doesn't cover it. And it can get costly. It's $45 for the first 2 doses. And again, you're giving this weekly until your baby is 3 months of age. And you have to take into account if your baby spits it out or has a missed dose. And then you can only have so many, you can only have a short supply of the medication because it has to be made, or else it loses its effectiveness that way too. And so because of its less than optimal effectiveness, certain procedures are limited, such as circumcisions. It's just not recommended to do something like a circumcision if you don't give vitamin K that is going to help your baby stop bleeding. So a one-time IM injection is the standard of care. And if anything, this is the one thing that I would 100% give your babies. Some parents will say that refuse it, say, well, this is really rare. So why would I give my baby a shot for something that we never see? Well, the reason we never see it is because we've been giving the shot for some time now. I have seen babies that have been admitted to primary children's with a brain bleed. And when they look back and say, okay, this baby's 3 weeks old or 2 weeks old or whatever, and they're trying to figure out why this baby has like these brain bleeds, and maybe they were seizing at home, or there's something that initiated the parents to bring the baby to the hospital, and they would look back at the newborn record and no vitamin K was given. So it does happen. It can happen. So this is something not to take lightly, and it doesn't matter how good of a diet you had when you were pregnant, how healthy you were, it doesn't cross the placenta. So your baby is going to be born deficient in this. And even when we have babies that have some type of bleeding issue going on at birth because they're sick or something else, the first thing we ask is the baby get vitamin K, and sometimes we even give a second dose because it's part of the clotting cascade and helps your body clot blood, which can be life-saving. Hepatitis B vaccine. So hepatitis B, just as a reminder, is a disease that causes inflammation of the liver. Many people don't know they have it. It can be spread from mother to child during the birthing process. Infants who get infected with hepatitis B aren't generally just going to have an acute process. They're very likely to develop chronic hepatitis B. If you get hepatitis B later in life, you'll usually just have an acute phase and you don't develop chronic disease. But if the younger you are and you're exposed and have an infection, the more likely you are to have a chronic hepatitis B disease process. So this can cause liver damage, liver cancer. Hep B is a leading cause of liver cancer worldwide, cirrhosis of the liver, and can cause death. So this is something else you can do for your baby to start them having a healthy lifestyle and hopefully a long, healthy life. It's a 3-dose vaccination, and the first one is part of the newborn medications. So they'll get, usually we call it eyes and thighs. You get erythromycin, vitamin K, and hepatitis B. So if you have any questions about those things, please talk to your pediatrician or your newborn provider about it, and just make sure you're educated. Everybody wants to do what's best for their child and their children. So there's no judgment. Just want to make sure that you're fully aware of why we're doing this and why it's important, and then you can make your decision for your baby. So as Hippocrates said, wherever the art of medicine is loved, there's also a love of humanity. I think I can speak for myself and my colleagues that I work with across Intermountain system. We all want what is best for you and your baby. We want you to feel comfortable where you deliver, and we want you to be knowledgeable about the services that are offered at different hospitals. And we all just want a healthy baby and a healthy mama. So thank you. Reach out if you have any questions. Happy to answer emails or anything you might need. Thank you.
Awesome. Thank you so much, Taylor. We appreciate your time and putting together such a thorough slideshow for us and for the new moms, and just happy to have all of this information. Joanna, do you have any final questions or?
Yeah, I mean, I have questions and I have thoughts. I mean, I feel like I could talk for another hour with you about this. I am so thankful for all the information that you've provided. It was very thorough, as Perry said. It's full of tons of information. And I think that, you know, if we look back and look at the themes, so much of it is prevention in terms of the medicine that is given to our babes. And it's a very personal choice for families, but you don't know what you don't know. And so if we can put people in the know, they can make the decisions that they're comfortable with, and that are hopefully best for their children. And then the other thing is just the vitamin K for me was, I mean, because I learned about this so long ago, I'd forgotten a lot of it, but vitamin K is so interesting to me because we learn so much about, or we hear so much about what you do to your own body and what you ingest in your own body. So much of it transfers to your child in utero, but vitamin K does not. And so that was something that really stood out for me. So thank you for your perspective and your expertise. And everybody listening, Taylor is such an incredible community resource. The fact that you work in our community hospitals and our well baby hospitals, but all the way up to these neonatal intensive care units. And the fact that you know all these teams at all these different hospitals is so incredible. So I do encourage anybody listening to this to reach out to Taylor. She's been so welcoming for any inquiries. And yeah, I've got tons of questions, but I know we're out of time. So I will email you.
Yeah, feel free.
Thank you so much, Taylor. I know that this will be incredibly impactful for the people who are listening and are parents to be, or parents second, third time around, because you can never know too much.
You're welcome. Thank you.
All right, everyone. Enjoy our other videos on our YouTube channel, and we will see you next time. Thank you.
Thanks.